I'm totally happy. So good afternoon. Welcome to Emergency Excerpts. And today's topic is, I know you're all going to know this. I'm positive you will. Let me get there. I'm just going to share my screen and get us to our primary slide. And currently I am, for whatever reason, in love with this music. So of course I have to sing. Goodness gracious. We don't talk about Axis, no, no. We don't talk about Axis, no, no. Oh, how his heart is hurt, oh, and he doesn't have the flow. Oh, no, it don't go. That's my song. I just developed it, so it probably needs some work. All right, and just wait. I think everybody on the line are Grady employees, but at the end, I'm just going to have some quick talks about some things that happen in critical care that we all want to know about. Some things are particular to CVICU, like TTM and ROSC, but other things are issues, and they're small issues, less than a minute on each issue. Just some explanation about things that are coming up and sometimes causing a little bit of conflict. So I want everybody to be aware. At the end, I'm going to just talk about that. But first, we're going to talk about Axis. So we just think about simply about activation of the heart. All of us know that it starts, or it should start, in the sinus node. And after it starts in the sinus node, or electrical current actually is activated from the sinus node, it is then deployed through three major pathways in the atria. Those are called the internodal pathways. They carry the impulse out and distribute it equally to the right atria and the left atria, all at the same time. And the impulse is gathered in the AV junction. And of course, in the AV junction, the impulse is held. Now, the reason that it's held and the way it's held is that in the junction, you have a combination of what we call slow and fast channels. What all that means when we say slow and fast channels is some channels open their doors quickly and ions travel through them rapidly. Those are called sodium channels. And other channels open their door slowly and the ion moves slowly, and those are the calcium channels. But when we talk about our pacemakers, so sinus node, AV junction, Purkinje fiber, are primarily fast channels that automatically depolarize, and that's what's sending the current out. So current starts in the sinus node, is distributed through the right and left atria, really virtually at the same time, gathered up in the AV junction, delayed there. Beautiful property of delay here to allow time for the atria to contract in order to fill the ventricle. And then that impulse is rapidly distributed down the right bundle and to the left anterior and left posterior bundle. So when we talk about current, when we talk about depolarization, we're going to use another term as well. That term is vector. Vector is the instantaneous depolarization of cells and its direction of current. So all your cells are depolarizing basically at the speed of light, right? Because you depolarize your ventricles in less than 0.08 seconds for a healthy ventricle, really fast depolarization. And you have all these instantaneous vectors, which actually are directional pointers of where the current is traveling. Now, when we add our vectors together, we get three mean vectors, and we'll look at that in just a second. And then we ultimately get one average. And that average, so that average vector is called axis. Axis is the combination of all the instantaneous vectors, all gathered together in the average. So it's just like a million people taking a test, and we give the average result from the test from those million people. We have these million vectors in the heart. We average that all together, and that tells us about the average directional current of depolarization. That's what axis is. So when we think about axis, we normally will say, we look at our average vectors, the three, The first vector depolarizes the septum from left to right, and it depolarizes the right ventricle. And that happens generally really fast because the right ventricle is a thin muscle, doesn't require that much current. The main vector is to the thickest part of the heart because it requires more current, and that is the apex. And the third vector is up to the base of the left ventricle. So to the right, to the apex, to the base, to the right, to the apex, and to the base. And actually, what's so gorgeous about this is that's what gives light to the terms Q, R, S. So if I have a positive electrode that's down here, first I see current going away from the positive electrode to the right heart. That will instill a Q wave, a downward wave. Then when the current comes towards my positive electrode, so we're talking about like an elite 2, I get a big upright. That's the R wave. And then when current goes up to the base of the heart, it's going away from the positive electrode. That's going to give an S wave. So really important whenever you come to any kind of a class about dysrhythmia, STEMI, axis, just to remember that there is a purpose in having good lead placement. And that is because that's what sets up the photography, the visualization of direction of current. And it's always important to remember that if I'm just making up leads now, I have a lead here, that's the positive electrode, and another lead here that has the positive electrode. I'm going to see exactly opposite because I'm going to see the current traveling at the same time. But remember that big current going towards that positive electrode will give me an upright. But if I have a positive electrode up here and the big current is going away, I'm going to have a big downwards. So that's really important for us to consider when we talk about electrical current. Now, really, in order to be more clinical, more specific, more physiologic, it is really important to remember, right? Sinus node to the internodal pathways, and that one pathway, this is not a very good drawing. It's beautiful. That's why I chose it. But one pathway goes over to the left atria. And then you have those two pathways that go actually to the AV junction into the common bundle of His and have those splits, right? The right-sided bundle, the left anterior, and the left posterior. And you can see the anterior bundle is shorter. It's much more fragile than the posterior bundle. And you'll remember from other times that we've had class that the right bundle and the left anterior fascicle are actually receive oxygen delivery from the left anterior descending coronary artery, or prior to bifurcation, the left main. Now, if you have a left main full occlusion, you're probably not going to survive to get to the hospital. But if you have a left anterior descending proximal occlusion, meaning close to the aorta, you will see a patient that will present with right bundle branch block and left anterior fascicular block. Now, 2 weeks ago, we did a talk about this, which was really important. And at that time, there were a lot of requests that came in that said, we want to understand axis better. So that's why we're doing an axis talk today. It seems a little backwards, and I'm so sorry. Should have probably done that first, but it doesn't matter because it's going to really help us understand. So again, what we're going to remember is these are electrical pacemaker cells designed in the pacemaker pathway, sinus node, AV junction, Purkinje fibers, and all of their connectors designed to actually automatically open the channel in their wall and allow ions to come in. That's known as automaticity. So by the way, these are your design cells, but any cell anywhere in the heart can achieve automaticity when your electrolytes are out of balance or when you have oxygen delivery through the coronary artery, oxygen delivery problems. So automaticity was designed in the healthy heart to be in the sinus node, the AV junction, the Purkinje fiber. And in an unhealthy heart, it can happen anywhere in the atria, anywhere in the ventricle, multiple places in the atria, AFib, multiple places in the ventricle, VFib, or just anomalously in what we call a circus reentry. So basically it goes around and around in the ventricle without stopping and pausing to allow time for the atria to depolarize and contract. And that would be called VTAC. So VTAC is a reentry dysrhythmia, VFib is a multifocal dysrhythmia. Okay. So all about axis, all about axis. Axis represents that average of all those millions of instantaneous vectors. So the average of the current that is directionally averaged of the current that depolarizes the heart. So it's just the sum of all the electrical activity. So let's just think how simple what I just said was. If I have an area on the myocardium that is infarcted, it's no longer depolarizing. So it's taken out of the average. So remember I said 1 million people took a test, 500,000 got 0, 500,000 got 100. That made the average of the test 50. Okay, so if we're looking at all those cells in the ventricle getting depolarized, we're just going to call it 1 million. I'm not saying that's the number. We call it 1 million. And we're looking at the average between all those cells from 0 to 100, and the mean average is 50. Okay, so I'm just making this up like a test. So now I say that out of the 500,000 that were at 0, I am now going to reduce that 500,000 to 200,000 because 300,000 of them are no longer participating, just like in a myocardial infarction, no longer participating. So that means that you're going to shift your average. And the shift in your average is what's called an axis deviation. An axis deviation basically occurs for one of 3 reasons. We're going to mention them over and over and over again. And this is why it's so important to understand axis. Because of an enlarged ventricle, hypertrophy, because of a conduction deficit, typically bundle branch block or fascicular block, either anterior or posterior fascicle of the left bundle. So hypertrophy, bundle branch or fascicular block, and myocardial infarction. So why is axis important? Because it helps us to focus on what the problem is. The fact that you have an axis deviation is not the problem. The fact that you have an axis deviation tells us that you have a problem that we are obligated to discover. That's why we look at axis and axis deviation. So remember, as you are depolarizing the ventricle, directions are continuously changing, but we're just looking at that average point of activity. And in general, the average point is pointing to the patient's left side and down towards the foot. So we're going to say average axis is to the left. You can see my hand, left foot, the left foot, which is really where the apex is pointed. And remember, the apex is the largest muscle mass of the myocardium. So whenever you see a shift in that current that we're going to call the axis deviation, your question is, do you have bundle branch block? Do you have hypertrophy? Do you have MI? Now, those are the 3 main reasons. There are other reasons, but those are the 3 main reasons that we see the axis deviation: hypertrophy, conduction deficit, and loss of myocardium. So the thing is, you can memorize all the lists you want, but if you understand a big heart takes more current, a deficit in your bundles delays the time of activation, and loss of myocardium, dead man, don't depolarize. Dead myocardium, don't depolarize. That's it. Big heart, slow conduction, dead myocardium, don't depolarize. That's why you get an axis deviation. So again, I thought it was so important. I said it more than once. The big 3 causes: infarct, hypertrophy, conduction deficit. So incredibly and profoundly important, because when we're looking at an EKG, we have a lot of things on our mind and a big agenda. This should be the simplest thing. And I'm going to try to, and I'm going to tell you, it's not that simple. There are many things that we could consider, but we're going to do a simple strategic way to rapidly look at the EKG and evaluate what the problem is. That's what our goal is to make it simple so we can apply it. And by the way, you can't just attend this class and then not look at an EKG. As soon as you get off the phone, next time you're at the hospital, you have 2 minutes, look at your patient's EKG, look at their axis on the frontal plane, that's with the limb leads, and their axis in the chest leads, the precordial leads through the horizontal plane. And Honestly, after you've done it 10 or 15 or 20 times, you've got it in less than 5 seconds. And oh my God, it's such a window of opportunity to look at a dysfunction. So for now, we're going to start with frontal planes only. Okay, so in the frontal planes, what we talk about is you are always evaluating the direction of current. Okay, so this is representing here. We're representing AVF, lead 3 and lead 2, all of which the positive electrodes on the left leg. We're talking about frontal plane leads. And you always expect that picture to be upright. Okay. If you have a positive electrode on the left side, that would be AVL and lead 1. You also expect that picture to be upright. It might not be quite as upright, but you are on the left side. So any electrode on the left side, that would be AVL lead 1, or on the foot side, 2, 3, and AVF, you expect to see an upright picture. Now, I don't want to call it positive because that's very confusing. I'm talking about positive and negative electrodes, and I'm talking about above the baseline, upright, or below the baseline, downward. Upright, above the baseline, downward, below the baseline, when I'm visualizing ventricular depolarization. Now, if my positive electrode is over here on the right side, current, you can see the current is going really towards the apex, shifted a little to the base. Current is going towards that apex, which gave me that big upright in the positive leads that are on the left side and the foot side. But if I had a positive electrode up here, that would be like your V1 or your AVR lead, where you have positive electrodes on the right side, then you're going to see a big downward. So, and look at the fact that they're absolutely opposite each other. Now, if we were talking about a STEMI, we would call them reciprocal. And we're going to do that here as well. They're reciprocal to each other. When you have leads on the opposite walls of the heart, you see mirror image, and really it's upside down mirror image from what you saw on the opposite side. That's what we call the reciprocal change. So again, when we're thinking about axis, what we're going to do when we look at an EKG, we're going to say, are you predominantly upright? Are you predominantly downward? Or are you both downward, upright, or just upright and downward? So close to being zero, meaning looking at what's above and what's below is almost at zero. That's called equiphasic. So that's really important. You're going to use your eyes looking at the EKG and say, is it primarily upright or primarily downward? That's it. That's all you need to do right now. That's all you need to do. You need to look at the baseline. The baseline is the flat line, right? And the best baseline determination is from the patient's T wave till their P wave. That's your best baseline determination. Are you primarily above or are you primarily below? That's all. That's it. Everybody good? I'm assuming you are. Okay, so now I'm just going to show you this man with the camera, and I would have liked to rotate him a little more, but I couldn't do it. You know, he's not a real man. He didn't do what I wanted him to do. Oh, wait, that is a real man. He didn't do what I wanted him to do. So I couldn't rotate him to make him look right with the camera. But this is your positive electrode for lead 1, also for AVL, but we're just going to choose lead 1. Positive electrode for lead 1, and with our 5 lead or 3 lead electrode system, that will be your black electrode. And then the positive electrode for lead 2, 3, and AVF, that will be your red electrode. So you can see the man is laying down looking up, and over here he's on the side looking towards the right. Okay. So this red I'm using to represent my red electrode. If the current is going there, the picture will be upright. And that's normal because we expect the current in the heart to be going towards the foot and also towards the left. So we're going to expect the picture in the lead that we choose. So primarily we're going to choose AVF, but you could use lead 2 as well. We're going to choose AVF. AVF. If the picture is upright in AVF, the current is going towards the foot. Good, that's happy. And then we're choosing lead 1. So we're going to use AVF and lead 1. And if the current is going towards lead 1, the picture will be upright. So upright in AVF, upright in lead 1, that's going to be a normal axis. And that's what your expectation is when you look at an EKG. Is it upright in lead 1, upright in AVF? If they're both upright, that's a normal axis. Now this is quick look axis. It's quadrant axis. It's not It's not looking at a hexaxial wheel that takes longer than an hour. It's something that you can easily do, and I teach it all the time, but it takes longer than an hour. And I want you to have something quick that you can leave here and apply immediately. Okay, so now we're going to look at our patient. So given a hexaxial designation, we're not going to do that right now. You're upright in 1 and upright in F. That's a normal axis from your frontal plane leads. Okay, so that's the frontal plane leads, upright in 1, upright in F. That's normal. Okay, sorry about that. I guess I messed up with my animation. So if it's upright in AVF, that means current's going to the foot, but it's downwards in lead 1. That means that it's pointing towards the foot, which is in this case now going to represent the right side. It's downwards in 1, which means current is going away from the left and it has to go somewhere. It's going towards the right. This is called a right axis deviation. If it is downward, meaning the current is going away from the foot, downward in F, but upright in lead 1, that's a left axis. Okay, it's pretty simple. If it is current goes away from the foot, so it's downward in F, current's going in the opposite direction, and downward in 1, this is an extreme axis. Okay, so in order for us to appreciate this, we really have to remind ourselves that we have to understand our lead placement, and that the leads, when we talk about lead 1, the positive electrode, which is the camera of the lead, is on the left arm. And for AVF, the positive electrode, which is the camera of the lead, is down on the lower chest. You're not putting it down on the leg or the foot. You have it on the left lower chest, usually around mid-axillary, and you expect that both of those will be upright. So I just gave this little diagram. If you're upright in lead 1, upright in AVF, it's normal. If you're upright in lead 1 and downward in AVF, that's the left axis. If you're downward in lead 1, but upright in AVF, that's a right axis. And if both are downward, that's severe. Now, I don't think it's a good idea to memorize this, right? I think you have to remind yourself the positive electrode is the seeing eye. And that's what we looked at. Oh, sorry. I want to go backwards, but I have to re-animate. That's what we looked at here, is that the seeing eye of the camera is your positive electrode. That positive electrode, when current comes towards it, instills an upright. When current goes away, instills it downward. That's it. Positive electrode is the seeing eye of your lead. That's why you've got to be sure you put leads on correctly in the right space, because that's what's going to help determine what's occurring for your patient. If current in the heart comes towards the positive electrode in the frontal plane lead, if it comes towards the positive electrode, the picture will be upright. If it goes away from the positive electrode, the picture will be downward. So we have to go through this again. I'm so sorry. Okay, so now let's try a little bit. Okay, so I've given you this. You're not going to have that at your bedside, but you know, maybe you will. Maybe you'll print it and laminate it. So look at this patient. Okay, here's lead 1. Here's AVF. Are both of those upright? Yes or no? Okay, lead 1, AVF, both are upright. Upright in 1, upright in F, normal axis. Yay. Okay. Now we're going to look at lead 1 and AVF here. And lead 1 is predominantly downward. So that means it's going away. Current is not coming to the left. It's actually deviating and going somewhere else, which is what you're trying to figure out. And it's upright in F. So downward in 1 and upright in F means this is a right axis. Okay, now we're getting a lot of clues from this, but we don't have absolute confirmation. We're not going to have any confirmation until we look at the chest leads. So very important to remember, you're doing this to help you understand the axis, but it's going to become much more clear when you're looking at your chest leads. Okay, so you can yourself say, oh, look, I'm upright in 1 and I'm downward in F. If it's downward in F, the current is going away from the foot, but it is going towards the left because it's upright in 1. So that's a left axis deviation. Okay, and I have to be able to see this. My little bar at the bottom is covering me up down here. Okay, so now we're going to say you are upright in 1 and downward in F. And again, you're upright in 1 and downward in F. That means current is not going to the foot, but it is going towards the left. That's called a left axis deviation. We're going to do 1 or 2 more. Okay, taking a look at this one. In lead 1, you are predominantly downward. And in AVF, you are upright. Voltage is really small. We're not making any other diagnosis here. We're just saying predominantly downward in 1 and upright in F. So downward in 1, upright in F, that is a right axis deviation. Okay, so why do I care about this? Well, first of all, lots of times you're going to see patients who have SVT aberrantly conducted, but with VTAC, you will have an extreme axis. That means it will be downward in 1 and downward in F. That is very definitive for diagnosing VTAC. It's also what occurs when you have a pacemaker. So it will be downward in 1 and downward in F. It's an extreme axis deviation or undetermined. People call it no man's land, Northwest Territory. There's all sorts of names for it. This is why we don't talk about axis, because there's so many darn names for it. But what it means is it's not going toward the foot because it would have had to be upright in F, and it's not going to the left because it would have had to be upright in 1. It's downward in 1, downward in F, meaning current is going pointing up toward your patient's right shoulder. Now that's very common when you have a pacemaker. Now you might see in dextrocardia, that's so unusual. That's not even something we're thinking about. We see a lot of VTAC, or we see a lot of SVT with white QRS, with the right bundle branch block. So really, really important that you can almost 100% rely that VTAC will have an extreme axis when you look at the frontal plane leads. That paced rhythms will have an extreme axis, because remember, your pacemaker wire is embedded really in the septum. So your current begins at the apex and then goes upwards, which is why you get that extreme axis deviation in a paced rhythm. And that's really important, because if you have extreme axis in your frontal plane leads, you're going to say, well, is it VTAC or is it a paced rhythm? Maybe I don't see the pacer spikes, but my patient is awake and alert and he's talking. Well, probably 85%. That's a paced rhythm and not VTAC. It could be VTAC, but probably not. Now, right axis deviation, there are many causes of right axis deviation, but what we're going to think about is right axis deviation. You may see, actually you won't, sorry. So right axis deviation, you're going to see when the right ventricle is big, right ventricular hypertrophy. Remember, number 1 in axis deviation, do you have a big ventricle? So in RV hypertrophy, your axis will deviate to the right. Well, that's a pretty big clue, right? I'm looking at somebody who I don't really know. They've come into the ECC. I'm trying to determine, do I think they've got a pulmonary embolism? Well, they got a right axis deviation. You almost always say, well, that's confirmational. You also have a right axis deviation when you have cor pulmonale, you have chronic pulmonary disease, you have a developed right ventricle. The time for conduction is not delayed, but the amount of voltage is increased. That gives me a right axis deviation. So with right ventricular hypertrophy, right bundle branch block, and with posterior fascicular block. Now, if that's all you have, if you have only one fascicle blocked and it's posterior, it's going to be a little hard to diagnose that just from the fact that the patient has an RBB. But a lot of times you will see other indicators that are really important with the posterior fascicular block. And if you have a right axis deviation, you can't make a case for right ventricular hypertrophy. Patient has healthy lungs, his right ventricle looks good on echo or POCUS, and he doesn't have right bundle branch block. You can pretty much assume that he has blocked the fascicle on the posterior wall of the left ventricle. Something else that can cause a right axis deviation is a bypass of the delay circuit through the AV junction. That's known, there's two types under the term Wolff-Parkinson-White, where you have rapid conduction tissue that goes outside of the AV junction, connecting the atria to the bundles, and you rapidly activate because you have no delay time. So actually, the P wave is occurring at the same time that you start to activate the bundles. So the P wave goes right up into the QRS. That's called the delta wave. It's not rare, but it's not frequent either. But Wolff-Parkinson-White is something that we see. And typically with Wolff-Parkinson-White, patients present with very rapid heart rate, but they don't have hypertrophy. They don't have a bundle branch block. They don't have a myocardial infarct. But what they have is the loss of the delay segment between the P wave and the QRS. That's called the PR segment. So the P wave goes right up into the QRS. That's known as the delta wave. Usually an EP doc is going to diagnose that. You might have a cardiologist who says, oh, I think that it's a WPW. And sometimes we have fantastic ECC docs that are all about EKGs, but it's pretty discreet. So most folks don't diagnose it from an EKG. And it really requires that you know what to look for. And the only other symptom is the patient says, my heart is beating really fast, coming out of my chest. I feel a little short of breath. And, you know, their heart rate is 140, 150, 160. Okay. And adenosine sometimes can make things worse for patients like that. So just being aware of it. Okay. So always ask the question, could it be WPW? Because that's going to actually affect what we decide to do for the patient. Okay. With a left axis deviation, so we can see that in pregnancy, and that's because of movement of the heart, actually, because as the abdomen engorges and the diaphragm lifts up, the heart shifts. So the apex is pointing more to the left side than it is to the foot side. It's not a electrophysiologic abnormality. It's a shift in the heart because of the accommodation of space from the fetus. So that's in pregnancy. Left anterior fascicular block, the anterior fascicle of the left bundle, when that's blocked, current comes from the posterior surface to the front. And that gives us posterior surface around the front. And that gives us our left axis deviation. You can also see that with WPW. One is type A, the other is type B, and that's really determined by the axis. You could see it in pulmonary disease, less likely. Really common, really common to see left axis deviation when you've had an MI. An inferior wall, an anteroseptal wall, anterior wall, all of those walls, axis deviates almost always to the left. You've lost electrical conduction in the left ventricle, so current is going away from that. So if it's inferior, the current is going up to the left. Anteroseptal going up to the left, pure anterior going up to the left. Left axis deviation in a situation where you are evaluating somebody who's having acute chest pain, has a change in their HS troponins, you think that they're having a STEMI, you're not positive, maybe they don't have a T segment elevation, but they have an acute left axis deviation. You should consider that this is probably a myocardial infarction. And hyperkalemia, anything that alters electrical content of the cells can cause abnormal conduction. And of course, last but not least, left bundle branch block. So again, what I would remind you, right axis deviation, pulmonary disease, RVH, RBB, these are more discrete. So our big worry will be these. With left axis deviation, LBB and MI, also want to consider left anterior fascicular block. But if the left anterior is blocked, your right bundle is blocked as well. So that's really important for us to remember. And in general, that occurs. Now, this is grayed out on the other side because we're going to talk about that later. Okay, so now again, we're going to go back and we're going to talk about our axis, right? I'm not going to do any circles. Now I've got a full 12 lead EKG, but remember, I'm looking at lead 1 and AVF. Everybody can agree you're upright in 1, downward in F. So you are deviating to your left. And there's a very particular reason that you deviated to your left. And I hope I'll return to this later and tell you. Okay. Again, not looking at the chest leads right now. We're going to look at them later. No worries. Don't worry. You're not missing anything. We're just looking at lead 1 and AVF. So it's downwards primarily. You have a little upright, but it's downwards primarily in 1 and downwards in F. So current isn't going to the left and it's not going to the foot. It's an extreme axis. Extreme axis. Okay, well, that's pretty concerning to us because remember, you see an extreme axis when you see patients with VTAC. So you're always going to be concerned, is this VTAC? What is my patient doing? Does he have a pulse? Does he have a pacemaker? Remember, paced rhythms will look that way as well. Okay. All right, and taking a look at this, you can see that you're primarily upright in 1, primarily upright in F. So that means this is normal. Whew. Thank goodness we got a normal. Okay, primarily downwards because you're about 4 boxes up and about 10 boxes downwards. And so you're primarily downwards in 1 and primarily downwards in F. Yet again, that is an extreme axis. Now this one for me would be one I would do on a hexaxial because I have a little consideration that it may not be at the highest level of accuracy to just do the quadrant approach, which is 1 in AVF. Okay, now we look at ones. This is AVR. This is, you only have 1 beat on your lead 1 here. So here's 1, primarily upright. Here's AVF. Really equiphasic. So because it's equiphasic, I'm not going to say it's upright or downwards. You got a little upright, then a downwards, then another upright. I think it's equiphasic, but that means that we're pointing to the left. So this is the left axis deviation. Okay. And this one's pretty simple. Lead 1 is upright, AVF is downwards. This is a left axis deviation. Okay. Again, upright in 1, downward in F, left axis deviation. Here, this is pretty equiphasic. Same thing with AVF. So what I'm going to tell you is that I wouldn't feel that I could call this on a quadrant. I'd have to do a hexaxial on this. That's okay. So already okay to say, listen, the voltage is so low, I can't define what's occurring here. That's okay to say. I promise you. All right, lead 1, you're upright. AVF, you're upright. Normal axis. Lead 1, you're upright. AVF, you're downward. Left axis. Remember, lead 1 represents that left side. Okay, so I gave you a little chart with those, but once we move forward, we're not going to have the chart anymore. That's okay, because although I would love for us to be able to unmute and shout out our answers, it just may not work out for us today. Okay. All right. So now we're going to move to the chest leads. And there's only 2 things that I'm going to do on the chest leads. Now, remember that chest leads are horizontal plane leads. So they're looking into the heart, meaning not down the front of the heart, but into the heart. And so we expect that every lead will have some level of positive or some level of upright, some level of downwards, some level. On the right side of lead V1, we expect a very small upright and a relatively big downward. At around V3 or V4, we expect to see more upright than downward. And in V5 and V6, we expect to see almost all upright. So look here, you can see V1 is primarily downward, V2 is primarily downward, V3 is getting close to equal, and V4 more upright than downward. Everybody agree? This is called R-wave progression. R-wave progression means that you have a small R wave, it gets a little bigger, it gets bigger, bigger, and then stays about the same. So small, bigger, 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 same, same. And it's like a little staircase. That's what R-wave progression is. As the lead, so looking at the patient, remember, you're looking at, on your left side is your patient's right side. That from the right side of lead V1, you expect to see a very small R wave. You might not even see an R wave. But as the chest leads go across the chest, what we expect to see is bigger and bigger and bigger uprights. Okay, that's called R wave progression. And when we look at the EKG, and this seems to be the hardest thing for folks, so I'm positive it must be in the way I'm teaching it. So I'm going to try to teach it a little differently. When you see a lead where there is more upright than downwards, that is known as the zone of transition. Now, your heart, my heart, if we're normal, our zone of transition is in V3 or V4. That's the normal zone of transition. But when you have an infarct, when you have a right bundle branch block, when you have a right bundle branch block, let me say that, you will transition much sooner because current is all going to the right side of the heart, so you get a really big upright. So zone of transition usually occurs in V1 or V2 when you have a right bundle branch block. If you have a left bundle branch block, zone of transition happens much later. So the directional current is to the left, but it's going to transition to more upright than downwards much later. So one of the most important definitions for right bundle branch block, early zone of transition; for left bundle branch block, late zone of transition. Normal zone of transition, normally V3, V4, meaning more upright than downwards. Might happen in V3, might happen in V4, either one is good. If it happens in V1 or V2, you've got a problem. The most common problem is right bundle branch block. If zone of transition happens in V5 or V6, you have a problem. The most common problem is that you've infarcted your anterior septum or your anterior wall. V1, V2, anterior septum, V3, V4, anterior wall. So you got dead myocardium, not really depolarizing effectively, and all current is going away. So you don't see zone of transition to V5, V6. Okay, so this is really important because I'm going to do a basic axis from my frontal plane leads. And on the frontal plane leads, I'm going to say normal, left, right, undetermined. Then I look at the chest leads. And all I have to do with the chest leads is say, do you have an R wave that progressively gets bigger? And when is the upright, the R, bigger than the downwards, the S, or a Q? When is the upright bigger than the downwards? And that's called the zone of transition. I expect your R wave to get progressively bigger. I expect you to transition in V3 and V4. You have to remember that. You have to memorize that. You can't do this if you don't memorize that. You've got to memorize it. Okay, so small R, a little bigger, zone of transition, big and big. Okay, and you can see tiny to big. And it stays about the same size. Once you get to zone of transition, what you now are losing is the downward. You're not really getting any bigger on the upright, but you're losing the downward. Okay, so now we're going to look at this lovely EKG. Not that common for us to see these, especially if we're working with cardiac patients. Little r, little bigger r, bigger r, zone of transition, big, big. What the R wave didn't really get bigger, but the S wave, that's the downward wave after the R, gets smaller. Okay, so small r, bigger, bigger, zone of transition, big, big. And what I've lost is the downward here as I move over to the left heart. Okay, so zone of transition, oops, and your beautiful picture of R wave progression. It gives you so much information. You've infarcted your anterior septal wall. You've infarcted your anterior wall. Dead myocardium don't conduct. You've got left ventricular hypertrophy, current shifts to the left. You've got right ventricular hypertrophy, current shifts to the right. You've got right bundle branch block, current shifts to the right. You've got left or delayed to the right and shifted to the right. Or left bundle branch block, delayed but to the left, which is always the normal direction. Okay, so really, really, really very, very, very significant, because I'm going to use this to confirm and to assist me in making good diagnoses and good therapeutic decisions. Okay. All right. So again, we're going to look at our wave progression. So you can see here in V1, you are more upright than downward. This is your zone of transition. That is early zone of transition. The most common reason is a right bundle branch block. Early transition, right bundle branch block. Now I'm going to ask two questions. Did it take a long time? And yes, it did. And are the T waves inverted? Because on the leads where you have a bundle branch block, your T wave will be inverted. Yes, they are. This is a right bundle branch block. Remember, when you transition in V1 or V2, the most common cause is right bundle branch block. Okay. Now, I like to remind you about reciprocal changes, and I made this little chart today, like an hour ago, because I want you to understand that when you have a right bundle branch block, you really diagnose that in V1, and you diagnose it in V1 because you have a big R wave and it takes a lot of time. And your reciprocal change in V5 and V6 is that you have a deep S wave and it takes a lot of time. Your left bundle branch block, you're going to see that in V5 and V6. That's where you see it. And you see an upright that takes a lot of time. And in V1, you see a really big downwards that also takes a lot of time. So you're looking at the opposite from either wall of the heart. With right ventricular hypertrophy, usually that's diagnosed in V2. You've got a really, really big R wave, but it didn't take much time, just a lot of voltage. And over here in V5 and 6, you're going to see a deep S wave, but it's not wide. With bundle branch block, those waves are wide. With hypertrophy, the waves are not wide. Left ventricular hypertrophy, you're going to diagnose that primarily in V4, but you can also look at V5 and 6. And what you're going to see with left ventricular hypertrophy is a big, big upright, really big in V4. Normal zone of transition, but a big upright, really big, greater than 10 millimeters, usually greater than 15 millimeter voltage. That tells you have left ventricular hypertrophy, and you're going to have a big narrow downwards in V1. Okay. Now, I was trying to add another, I must have gotten a call or something because I guess I didn't finish. With the left axis deviation, lead 1 will be upright and AVF will be downwards. Those are reciprocal. With right axis deviation, lead 1 will be downwards and AVF will be upright. See how simple that is? All you have to do is in your mind say current in the heart always goes to the left, pointed towards the foot. That means any foot lead should give me an upright, any left-sided lead should give me an upright, and the frontal plane leads. And in my chest leads, I expect there to be a tiny or no R in V1, and I expect it to get progressively bigger. When the upright is bigger than the downwards, that should happen at V3 or V4. That's called zone of transition. I expect that always to occur. If zone of transition is early, most likely that's a right bundle branch block, could be right ventricular hypertrophy. But you know how to differentiate that. Right bundle branch block, direction is to the right, which is the wrong direction, and it takes a lot of time. Right ventricular hypertrophy, current goes to the right, but it doesn't take a long time. It's just big voltage, so it doesn't have a wide base. It's pretty straightforward and simple rules that really help us to look at those evaluations. So now, added to our frontal plane axis, we are always going to look at the frontal plane using lead 1 and AVF, and then we're going to look at precordial, and all precordial is, do your R waves get bigger, and what's your zone of transition? Okay, so if you have early transition, that means you have upright bigger than downwards in V1 or V2. That's early because it's not supposed to happen until V3 or V4. Early zone of transition, right ventricular hypertrophy, right bundle branch block. You also can see it in a posterior infarct because all current's coming towards the front. And it's something we can use in WPW, but it's not that important. What you want to focus on is RVH and RBB. If you have late transition, that means more upright than downwards in V5 or V6. You can sometimes see that, particularly in women. They may just have a small shift in their ventricular rotation, and especially in pregnant women. But it is a very good diagnostic criteria for anterior MI, anteroseptal MI, left bundle branch block, left ventricular hypertrophy, and left anterior fascicular block. So again, I want us to say we look here and then we look here to give confirmation. But what you see over here in frontal plane axis, you don't see an axis deviation with an MI in your frontal plane. You only see that in the precordial plane. So I can look at your frontal plane and say, I think you got a right bundle branch block, you got a right axis deviation, I'm pretty happy. But I'm going to look over at that frontal plane just to confirm it. If I have a left axis deviation, it might be a left bundle, it could be an LAFB, but the most highly likelihood is that it's an MI. So I'm going to go to that precordial axis. That's really going to confirm it for me. You've lost ventricular depolarization because you've had an anterior MI or an anteroseptal MI. Okay. All right, so now look at your patient. Let's start with the frontal plane. So here's the dividing line. Lead 1 is upright. AVF is upright. So your patient has a normal axis. And now we're going to look at your R wave. You have a little R, it gets bigger here, and here is zone of transition, V3. Now that's a normal zone of transition. Now you got a really big vector here, and you may actually, I think actually what I would say is I was just looking at these right before we got on. I think you actually transitioned in V2, okay? Because V2 is way up there inside that other lead. So I have so many things going on here. Let me go back. There we go. Okay. So I transition V2, which is early. And because my R wave is so big here, I'm going to call this right ventricular hypertrophy. Now I've got some other things going on as well, but our concern right now is R wave progression. So a little R here, a great big R there, and then the R's get a little bit smaller, and zone of transition was V2. Okay, now we look at this patient, and we've seen him before. We looked at him over here for his axis. We said he has, oops, upright in lead 1, downward in AVF. So that is a left axis deviation, right? It's left axis deviation, going to the left and away from the foot, left axis. Now I go to V1 and I can see he's almost all upright in V1. This is his zone of transition. And it takes a lot of time. He has an early zone of transition. It takes a lot of time. He has a right bundle branch block. Now, I don't want to blow the top of your head off here, but when you have a right bundle branch block, you always expect a right axis deviation. Your patient has a right bundle branch block with a left axis deviation. And that's abnormal. And what that always tells you is that, remember that left anterior descending coronary artery, it supplies the right bundle and the left anterior fascicle. Your patient also has a fascicular block. And there are other clues here that we're not going to do today that we've done before and I can do again. But what I want to say is if you have a right bundle branch block with the left axis deviation, 2 of your electrical pathways are not functional. That's called bifascicular block. If you add into that the patient has a prolonged PR interval, let me make sure you appreciate that your patient is really at risk. You need to be prepared. You need to know how to operate a transcutaneous pacer. You need to be prepared that if something happens, your patient's going to need to be paced. Don't waste too much time doing all sorts of other stuff, right? You have to do your ACLS. But if your patient had a right bundle and a left axis and a prolonged PR interval, it is highly likely that, first of all, they'll go into Mobitz type 2, or they may just go into complete heart block because that posterior fascicle is the only thing keeping the heart alive at this point. So really important. Why do we look at axis? Why do we care about this? Because we're trying to prevent disaster for our patients. So that's really important. Okay, so remember this patient, downward in 1, downward in F, an extreme axis or undetermined axis. And then we go over here and zone of transition is upright. V1, V2, V3, V4, all upright, but our zone of transition was in V1. Now, for this patient, we're going to say, well, look, he's got an undetermined axis. He's got an upright in V1 with early zone of transition. It is possible that this is a paced rhythm. I don't see pacer spikes. It is also possible that the patient has supraventricular tachycardia with a right bundle branch block pattern. So here's the thing. In either case, the most important thing is look at that patient, take his pulse. That's it. That's the most important thing because you are not going to be able to fully define him from your EKG. He has positive concordance on the right-sided leads. He has positive concordance in the left-sided leads. Positive concordance means on the right side, all goes in the same direction. On the left side, all goes in the same direction, primarily downward. Okay. So I'm not saying that any one of us, none of us, me not, none of us would look at this on a monitor and say, I'm okay with this, right? You wouldn't have said that anyway, but you want to have an expanded view. It might be a YQRS tachycardia. Don't be calling a code till you go in the room. You thought it was VTAC and it might be VTAC, but it could also be Wolff-Parkinson-White with a YQRS. So I'm going to go in the room. I'm going to take the pulse. I'm going to look at the patient. I'm going to see what's happening. Before I call a code, that's what I'm going to do. Okay. That's going to be a really important thing. Okay. All right. So we've seen this patient before too, primarily upright here, up in 1, up in F. Now I'm going to look at his R wave, and he has pretty nice R wave progression. You can see a small in V1, gets a little bigger in 2, bigger in 3, and he transitions in V4. Now, what's really important about looking at this patient is remember that in V4, that's when we diagnose LV hypertrophy. Now, a lot of times at Grady, we don't see LV hypertrophy without left bundle branch block. We see them together, but this is a pure LV hypertrophy. And you absolutely know that because you got this really tall R wave. It's really, really skinny and it's really tall. So you have a good R wave progression. Your zone of transition is normal in V4, but your voltage is really, really high. So you're going to consider the patient may have some LV hypertrophy. And that is really important because your patient has ST segment elevation, V1, V2, and V3. And when you have left ventricular hypertrophy or left bundle branch block, you will often see ST segment elevation, V1, V2, V3. So by the way, I would never activate a STEMI on someone who looks like this, even though I see that he has ST segment elevation. I'm very worried about that. I would always call a cardiologist and ask him to look at the EKG before I activated a STEMI. This patient represents the #1 cause of inappropriate STEMI activation, and that is LV hypertrophy. 70% of STEMI activations are LV hypertrophy. Now, that's not such a bad thing. You're in the CVSU, you're at work already. You're in the ECC, you're at work already. You're in the cath lab and you worked 12 hours yesterday with 4 STEMIs and an Impella, and you got called in at 1 o'clock for a fake STEMI, a false STEMI, and then you got called in at 3 o'clock for a false STEMI, and you have to be back at work at 7:30. So it is really important to remember that we want to be sure we're looking at all our diagnostic criteria here. So not just jumping off the boat because you got ST segment elevation, which is relatively subtle in this case, but isn't always. I'm doing an R wave progression. I'm looking at the fact that I've got this huge R wave, and I'm looking at the history and the patient's hypertensive. I think it might be LV hypertrophy. So before I call the POC desk and activate a STEMI, I'm going to ask the cardiologist. I'm going to call the cardiologist. I'm going to wake up one person, and that's the cardiologist, have them look at the EKG and tell me whether I should activate a STEMI because it's diagnostically uncertain. Okay, here we go again. Here we are in lead 1, primarily downward. Whoops. And all those are just telling you where I got these visuals from because they're from all over the place. Primarily downwards in 1, and equiphasic in AVF. So we're just going to say it's a pretty severe axis. And you can see your zone of transition is in V1. You've got some other really important criteria here. In particular, take a look at your P wave, how sharply spiked that is. That's a sign of cor pulmonale. And you have a right bundle branch block. So this is a right bundle branch block and almost normal, leaning to the left axis. Okay. I don't know why all sorts of things are coming up on here. Okay, so now we look at this patient and you can see upright in 1, downwards in F, that's the left axis. And again, right bundle branch block. Zone of transition is early and it's wide. You've got a right bundle branch block, but you got a left axis deviation, the most common partnership that you can see electrically. Right bundle branch block, left axis deviation, which means your right bundle and your left anterior fascicle are not functional, which means you're operating your heart on one fascicle only, and that's the posterior fascicle. So be aware, be concerned, think about the drips that you're putting your patient on. If you think you have to give them something that can actually slow conduction, you're going to be really darn cautious. Okay, so this patient, of course, upright in 1, downwards in F, and he is really lovely. We're so happy to have him here because first of all, he has a left axis deviation. Everybody already knew. They looked at lead 1. They said, oh, that's a little wide. That's weird. Now we go over to V1, V2, V3, V4, V5. Your patient doesn't transition until V6, and you have a very wide QRS. So you have here a left bundle branch block. Now you may also have an anterior infarct. And it might be an old anterior infarct. We know that patients with left bundle branch block, they muddy up our evaluations. But I want you to also see you've got this big, deep Q wave, and you have this very fat upright, and it's small. And you also have ST segment elevation. So yet again, I'm going to remind you, left ventricular hypertrophy, left bundle branch block cause ST segment elevation. So really, really important to remember that unless your patient has a profound presentation with acute severe chest pressure and an HS troponin that's positive, you're probably going to want the cardiologist to take a look at this. Now, I could go on for hours, but obviously it's time for us to end. But actually, we are at the end. How lovely. How wonderful. So I'm very happy. I went a little bit over. We started a little bit late, but not that late. I'm very happy to answer any questions. And if you're able to stay on, I just want to give you a few added benefits of a couple of things that have been coming up in our ICUs, that just to cover those really quickly. So first and foremost, any questions at all? Remember that you're muted, so you have to unmute if you have a question, or you can chat if you have a question. Okay. All right, so pretty sure I was recording, so I'm sure the recording has now stopped because I don't have a stop button. So I want to just talk about a couple of extra benefits for people in the ICU, just a couple of topics that have been coming up lately and that I've had some very nice discussions with some of our physicians. So I want to do it quickly. Okay, first and foremost, always, 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 if you have a patient on CRRT, they should receive heparin if they can, and that heparin should always be given through the IV port attached to the filter. Now, when you're setting up your CRRT machine, you're going to say no systemic heparin, no heparin, because when you tell that to the device, what the device is talking about is the syringe where it counts it as part of the INO. You're going to give heparin through an external pump through that IV site, and you're going to count that heparin as part of your intake. If your patient is on heparin because he has a DVT or a pulmonary embolism, or another reason to be on heparin, he had an ischemic stroke, whatever reason he's needing heparin and he's on CRT, you are going to give your CRT through the filter. Now, I've heard a couple of stories. We're going to work really hard to set everything straight. Okay. Unfractionated heparin means heparin that's bound to protein. Protein is not cleared at the CRT filter. So the majority of heparin enters into the systemic circulation. The heparin has to be released from the protein to be active at the tissue. So when you give your heparin through that IV port on the filter, what you're actually doing is delivering the unbound heparin, which is a tiny, tiny bit, into the filter to anticoagulate the filter, and the rest of the heparin goes into the patient. It does mean, however, that you will be adjusting your heparin by your anti-10A to receive your therapeutic level. Every time your filter clogs or clots, every time your patient comes off CRT, if they are receiving heparin for another diagnosis, it must come off the filter and go into the patient. And when you start your new filter back, it goes back onto your filter. If you would like to preserve your CRT filter and manage your CRT better, you're always going to give heparin through the filter. In the new order set, this will be the domain of the nephrologist, and you will always be asked to give unfractionated heparin through the filter. You should always give it through the filter. I heard that someone, I know who it was, and amazingly a cardiologist, who said, oh, you've cleared all the heparin, that's why the patient's not heparinized. No, that's not correct. That patient was actually heparin resistant. We don't clear all the heparin at the filter. We only clear the unbound, and it's a small amount. Okay, so please, please, please give heparin through your filter. No matter what unit you work in, give heparin through your filter. If your patient needs heparin for other reasons, quite honestly, that is your responsibility to know. You need to know your patient's diagnosis. So your patient had a PE, your patient had a DVT, he's getting heparin through his filter clogs, his filter clots, he's going off the unit, heparin comes off the CRT filter into the patient, and when you put the patient back on CRT, it goes back to the filter. Okay, good. TTM and ROSC. and temperature. Okay, we are going back to our original protocol, or not original, but our last protocol, which requires return of spontaneous circulation at 20 minutes. We're not going to take all patients, all comers, all time. However, we have a lot of variability. One of the number one things that JCH and the resuscitation committee for JCH say, you must rigidly obey your protocol. Well, the protocol that's in existence is ROSC at 20 minutes. We tried the expansion because there were a lot of physicians that thought that was appropriate, but we have discovered we're doing a lot of TTM with really poor yield on a lot of people who are brain dead when they come into the emergency room. Going back to return of spontaneous circulation, 20 minutes, that's 20 minutes from first medical contact. We will be putting that in. It's still the same protocol that's in place right now, but we'll be organizing it again. May 3rd, we're meeting with the Critical Care Operations Committee for the final approval. For inpatients, we do 33, for out of hospital cardiac arrest, we do 33-degree TTM. We're not going to do 36 degrees. It is not in our protocol. We have agreed that that is not beneficial. It was put into place, but people aren't keeping up with the literature. It is not beneficial. Patients shiver like crazy at 36 degrees. We're not doing 36 degrees. We do 33. If you're having trouble, you need to have your physician colleagues really probably should reach out to David Bauer. David Bauer said, if they call me, I'm having them call you, but he doesn't mean that. He's going to deal with it because it's going to be physician to physician. 33 degrees is what we do. 20-minute return of spontaneous circulation. We are going to utilize 37 degrees for in-hospital cardiac arrest. And that's because we can't validate out of the hospital whether you actually got good bystander CPR. Here's the belief. The belief is that if CPR is begun and is appropriate, you continue to have low flow to the brain, and therefore the damage neurologically is so much significantly lessened. Now, the problem, of course, is that you're already in the hospital and you have comorbidities. 33 degrees for out-of-hospital cardiac arrest, 37 for inpatient cardiac arrest. 37 degrees is still following a protocol. You don't just put patients post-cardiac arrest at 37 degrees. They will still shiver. And if they are shivering, they are producing heat, and you will be applying water flow at 4 degrees or 8 degrees Celsius against their skin, which will cause many secondary injuries. So for 33 and 37, shiver control is absolutely essential. Propofol, buspirone, Tylenol, propofol, fentanyl, dexmedetomidine, Demerol, paralytic. And you do not allow patients to shiver for an hour or 2 hours or 3 hours. You have to nip that immediately. And the reason we do EEG is so we can see if patients are shivering or seizing in a subtherapeutic mode. We're not doing EEG during TTM to diagnose their neurologic function. 7 days after you recover, you rewarm from TTM is when we're going to make neurologic prognostication, not during TTM. Okay, controlling glucose in the CV patients. So there's been quite a few questions about this. I'm sure, Jody, you're very interested in this. I've had a lovely, lovely discussion with Dr. Ward, and I think there was some misunderstanding. Okay, so first of all, stop saying they ordered glucomanner. They don't order glucomanner, they order insulin. Dr. Ward and I have agreed, I will be writing that protocol. I'm assuming that it will be ready by midweek. That protocol is that if the patient has if a CV patient, so it's only for CV patient has 2 consecutive blood sugars greater than 180, that includes what happened to them in the OR. 2 consecutive. So let's say they, on handoff, anesthesia says his last blood sugar was 190. On your next blood sugar, if the blood sugar is 195, your patient's going on insulin. Anything above 180 times 2 consecutive, the patient goes on insulin. The nurse has the right to do it. The protocol will be nurse-led. Obviously, you can always check with your APPs, but this is what the evidence shows is 1 or 2 or 3 incidences of hyperglycemia. Remember, glucose in the serum is not glucose in the cell, except for the brain tissue and the heart tissue, in which case all that glucose is being delivered and putting a terrible burden on the myocardium. You cannot allow these patients to be hyperglycemic. I 100% agree with that. She wants nurses to be enabled. So you have 2 blood sugars in a row greater than 180. Tell your APP, go on insulin. Dr. Ward will be meeting with the APPs. She's very pleased with how people are managing patients. But this one, I think she had some confusion, which was she was thinking you should just put the patient on the glucometer so you're doing blood glucoses. No, we don't add the glucometer to remind people to do blood glucoses. We only use the glucometer to deploy insulin. So your patient must be hyperglycemic. He's going to have a standing insulin order. You know he's hyperglycemic. You start insulin. You initiate the glucometer because that order is a standing order. And if you've had any trouble finding the standing order, we'll make sure that you can find it. So that's really important. SpO2. SpO2 is so incredibly important. It's a general reading, but we're measuring from the tip of the PA catheter all the blood that has returned back to the right heart. So that includes the coronary sinus, the coronary veins, the cerebral veins, the upper extremities, the lower extremities, mesenteric kidney, everything mixed up in the RV, ejected up in the pulmonary artery. It's a really meaningful measure. And many cardiologists and surgeons use SpO2 to tell them whether or not we have an appropriate cardiac output and appropriate hemoglobin carrying capacity. So SpO2 is really important. The problem is that at Grady, at other hospitals, you do a blood gas and you get the report in 10 minutes or 15 minutes. Sometimes it takes an hour, sometimes an hour and a half. That's too long for an unstable, fragile post-cardiac surgical patient. So what Dr. Ward has asked, and I can appreciate what she's saying, is when the patient comes into the unit, you're going to just input the SpO2 that was the last SpO2 measured by anesthesia and the last hemoglobin that they measured. But your commitment is within 30 minutes, you're going to draw venous gas so that you can recalibrate. And remember, you press that draw, which takes a snapshot of, you don't go forward, you press draw and you stay there. It takes a snapshot of the patient's SpO2 at that moment. And then when you get your SpO2 back, you are then going to calibrate. You also need to calibrate every night. I'm not dictating 4 a.m., but at the time that you standardly draw labs during the night, you need to recalibrate once every 24 hours. If we can achieve that, you're going to be drawing a lot less venous gases because you don't need to do a venous gas if you are calibrated. Last but not least, DKA versus non-DKA. I don't think it's been a huge problem in the ICU. It is a huge problem everywhere else. Glucometer is your method for deploying insulin. It is not your DKA protocol. There is no protocol associated with the glucometer. Glucometer is the method to give and to tell you about insulin adjustment. That's it. Insulin adjustment D50 if you have hypoglycemia. The DKA and non-DKA protocol are embedded in the Grady protocol. These are Grady protocols. In DKA, your goal with insulin is to obliterate ketosis. That's what your goal is. Yes, how lovely it is that we get glucose down, but we're trying to stop the breakdown of proteins and fats. That means you're treating ketosis. We don't measure your ketones because they stay in the serum and in the urine for a long time. What we measure is the gap. So if you have a wide anion gap and you are hyperglycemic, or you're a known diabetic with a wide anion gap, but your glucose is normal, you're going to go on insulin. And we're going to give you insulin, but as soon as your blood sugar drops 1 point below 250, you're going to go on D5-LR at 150 an hour. Now that's the protocol, because we got to protect the patient's glucose while we're obliterating the ketones. If your blood glucose drops below 150, you're going to go on D10 at 150 an hour. So down in the ECC, frequently we'll have D10 and D5-LR hanging. One or the other is being given. And that's the way it has to go until you have a normal gap, or until somebody says, oh, this gap isn't ketones, it's lactic acidosis. Until your gap is normal, Once your gap is normal, you should come off the DKA drip. It's very intensive because you're replacing potassium, you're using D5-LR 150 an hour, using D10 150 an hour, and you're going back and forth and back and forth. But you're there to protect the patient and to obliterate ketosis, because the more proteins and fats they break down, the longer they're going to stay in the ICU, the longer they're going to be on the ventilator, and the worse their survival statistics. Non-DKA, so much simpler, but you don't have a wide gap. Okay, so you're hyperglycemic and sometimes you're very hyperglycemic. With non-DKA, embedded in your Grady protocol is that your patient must be receiving 40 mLs per hour of a carbohydrate solution. So that carbohydrate solution will be D5-LR, D5 normal, tube feeding to goal, or parenteral feeding to goal. Okay, that's it. It's pretty straightforward. So, I feel that these things can be very, very, very confusing and confounding. And one of the reasons we come together is just to remind ourselves about how we're doing the right thing, and also what a great job that we're doing. So recently, of course, in CVICU right now, I think you have maybe 4 patients on TTM, because I think we got another one today. This is really wild. And the thing is that we would like to apply this intensive, nurse-intensive, high-risk, low-yield therapy to the patient population that is going to be bested with it. And those are going to be patients that have very, very short downtimes. So we've been very flexible in the CVICU. I say congratulations, fantastic job, always good, great, good, wonderful work. You've done a fantastic job, and you've been really flexible, because we had a lot of physicians that said, we just need to do it. There's no reason to have a downtime requirement, but there is a reason to have a downtime requirement. When patients have had 5 arrests in a row, that they've had a downtime of 145 minutes, right? Sometimes we have to actually be able to say, go in peace. We're going to give you love. We're going to give you care. We're going to have your family. We're going to be with you. We're going to be sure that you're clean. We're going to be sure that you're not in pain, but we're not going to torture you. And I think we have to really make a strong commitment to this. So again, I sent the new guidelines for resuscitation to Dr. Bauer today. And I said, just want to make sure you see, it says rigorous adherence to protocol. Rigorous adherence to protocol. So by the way, guys, don't get in any fights. It's okay. You don't need to fight. You don't need to get upset. We don't need to yell. We've just got to figure out a way that we can say, because we have a lot of different groups that manage patients in our CVICU. They're not cardiologists. They may not believe in TTM. That's okay. It's our protocol. This is what we're going to do. This is what the evidence at this moment says. And this is what we're going to do. We're going to do 37 degrees in inpatients and 33 degree in out of hospital cardiac arrest. And everybody and their brother doesn't get to say, I want to do 35, I want to do 36, I want to do 38, I want to do 32, I want to do 29. No, 33, 37. And I know how hard it is, because I know that there's been some difficulty. I've been called a few times. I know how hard it is, because people feel strongly, and physicians feel strongly that they're the physician. But I do think it is important to say that you are part of an evolution at Grady, and part of that evolution is we can no longer just do what we want. These incredible patients that we have the gift of caring for are not for experimentation. We're going to do protocol. The protocol is evidence-based, it's vetted, we've all agreed to it, we're going to practice it. And I know that in your hearts, because I know everybody on the phone right now, I know that in your hearts, you're holding in your heart. I see sometimes the suffering some of our bedside nurses are experiencing, feeling like this is a situation that's just so heartbreaking. And what can I do? And how can I make this better? And how can I make sure that we're doing the right thing? We can't ever know that we're doing all the right things, but we can agree that we're trying our best to do the right thing. And so we always want to have an open communication. We want it to be gentle. We want it to be embracing. We don't want people to leave from a conversation feeling angry. We need to be able to just say, this is our vetted protocol. this is really what we need to do. And I'm really inviting you to talk to Dr. Bauer, because if you really feel we should make a change, please, we're very happy to change. We're very flexible, but we're going to abide by these protocols right now. And we're going to have a couple of protocols that will be nurse-led. Obviously, you always want to talk to your APP, but the nurse-led protocols for SVO2 calibration and for controlling glucose in the CV patient. There'll probably be some more. We've got to show that we can manage these protocols and we can do it effectively. But one thing I will say, I think about Dr. Ward is Dr. Ward really wants the nurses in the CVICU to actually have a lot of autonomy, because that's what's going to be best for patients. But it has to be guided autonomy. And it just, again, just like physicians, it just can't be because that's the way I always did it. Or I have one nurse with a 30 years history, or another nurse who's got a really loud voice, or someone else saying you should be doing something, but it's not vetted. So we're just going to try to do a vetted practice. And I know you all want to do that. Last thing I just want to say, because I think mostly this is CVICU staff, is that I want you really, if you can, possibly, I know how busy you are, but I feel that our physicians and our APPs should not begin rounds on a patient without the bedside nurse. The bedside nurse needs to be a contributory person in rounds and needs to hear what's being said, because they're the ones who are enacting everything. Now, I'm not saying to you, because I know at one point they tried to initiate nurse-led rounds in the trauma surgical unit, and they had this sheet that was like what the residents do, all the labs and everything else. I don't think that's always necessary. But I think that you're the people who are caring for that patient. You have quite a window on them. Now, we're lucky in CVICU because we have this great band of APPs, and they're very involved with the patients, and they're very open to what you have to say. But you need to be in rounds at the bedside. I really want us to initiate that. I know it's a really strong desire for Marion, but beyond Marion, beyond anybody else, I just want to reiterate how important you are and how your voice needs to be heard. When you feel that this is wrong for patients and you have a reason to express that, you need to be able to do that and do that safely. So those are my tidbits for today. I'm pretty sure somebody's going to have a question about these things. So please feel free to unmute. Let's have a discussion if there is a discussion, and if you have the time, because we're at 5:30 or so right now. But if you have time to have a discussion or you have some questions, please ask.
Okay, Miss Barbara, I have a question for you.
Yes.
So patients on DKA protocol, right? You say blood sugar drops below 250, you should initiate D5 LR at 150. Right? So the patient is volume overloaded. Is there a part in the protocol that you can tweak the volume that the patient is getting?
No, because it's not about the volume, it's about the carbohydrates.
Carbohydrates. Okay.
They have to receive a certain amount of carbohydrates. But Jody, I love that you asked this, because you should always be aware of what the gap is, because a lot of times we have patients on the DKA protocol and their gap is narrowed and nurses are hanging D5 LR and D10, but the gap is narrowed. So that patient should come off the DKA protocol. So that's something to be aware of. If your gap is narrowed and your glucose is down, don't be hanging D5 LR, D50 or D10. Call your provider, talk to your APPs and say, the gap is narrow and I'm giving a lot of fluid here. Now, we have not made an accommodation for that, but I will tell you that I'm very, I mean, I have to do that with a pharmacist. I am happy to work with a pharmacist to put that in a CV perspective. So can't go live everywhere. That you might have to give a higher carbohydrate solution and less fluid. And we might be able to do that, but I can't tell you that. I have to work with a pharmacist for that. It would be something like D50 and maybe D50 in a dilution. That's why I need them. How would we dilute that? And could we give it at 40 an hour? So I'll look into that, and thank you. That is such a great question. But for now, you've got to follow this protocol. So if you called Dr. Ward and you said, my patient's glucose has dropped, he still has a wide gap, but now I have to give 150 an hour. She might say, okay, I'm going to take him off. I'm going to take him off continuous insulin. We'll just do long acting sliding scale because she doesn't want to give the fluid, and that's okay. So you always want to have an open communication. Thank you, because I didn't discuss that with her, but I will.
All right, another one.
Yes.
So the heparin going to the filter.
Yes.
So do you find that if the patient is on it for their PE protocol and you're putting it to the filter, that you take a longer time to get to that therapeutic level versus if it's being attached directly to the patient?
The evidence shows that that's not true, but subjectively, you may have seen that. It is true that you will titrate more assertively if you're giving it through the filter, because just again, I'm just going to make up a number. Let's just say we have 100 particles of heparin. 5 of them are dissociated from protein, 95 are bound to protein. So when I put that through the filter, the 5 that are dissociated get cleared by the filter. So now only the bound to protein heparin enters into the system, and it takes a little bit of time for that heparin to come off the protein to operate at the tissue level. So it is possible that you are seeing some delay. It is possible. But the problem is that if you don't actually achieve good CRT, you're going to continue to have acidosis, you're going to have hypercoagulation. So you're kind of saying, okay, how do I balance this? And honestly, again, I appreciate so much your very thoughtful question. Honestly, we might have to say that we're going to do anti-10A more frequently, which will allow us to adjust a little bit more frequently. That might be the solution. But again, if I'm looking at the global evidence, that has not been true.
Okay,
We should probably look at the evidence in our patient population of how long it takes for you to get to therapeutic goal. And do remember that you do have patients who are heparin resistant. So I think this patient, I think probably that your sister called me about over the weekend.
Yeah.
You know who I'm talking about, right?
I do.
So-
yeah. He gave us a run for our money for the past 4 days. I'm tired.
Yes. And the thing is that if he is on heparin at all times, whether he's on CRT or not, on and off with the heparin has to go back to the patient, back to the CRT device, and you're not able to achieve therapeutic levels, the probability is you are heparin resistant. And we've had a lot of patients who are heparin resistant. So I know that they DC'd his bivalve, but did the bivalve actually seem to work for him in anticoagulation? Do you know?
No, I'm not sure. I haven't been back to work just yet.
So we might do him for a case study analysis next week and talk about him because he's really very
That would
interesting. He'd be a great patient to do a case analysis on next week.
Yeah.
Cool. All right, good. Thank you, Jody. Shri, got us some questions, or does somebody else have a question? Anybody? No? Oh, I got a chat. Let's see. Oh, I don't have a link. Haja.
Yeah.
Just go to YouTube and search for Barbara McLean Critical Care. That'll be a link. I don't have a channel yet. I have to have 100 subscribers before they'll assign me a channel. Once I have a channel, everything I put up you'll get notified. You don't have to look at it, but you'll get notified. But I have to have the channel first.
Okay. Thank you.
You're welcome. Thank you for asking. All right, guys, very good. I'd love to answer any other questions, and I really think this is helpful, and I would love to just have a half an hour or so every week with the CVICU to just kind of talk about issues. And just to let you know that as soon as I heard about this glucose issue, I called Dr. Ward. I talked with her. We came to an agreement about having really good nurse led protocol. I'm writing the protocol. She said, I don't even need to see it. I trust that you're going to write the right protocol, but I want her to look at it. And then I'll work with your APPs as well, make sure everybody knows that that's what we're going to do. But she wants you to have a lot of autonomy because she believes it's important for you to manage those patients really aggressively to protect them. So I really like that. I know there's other things, and we always have personality differences and other things like that, but I'm really loving that we have a surgeon who really wants us to do the right thing and looks at the evidence and knows the evidence and really wants to help us. So I think that's good. All right, my friends, no other questions? All right, well.
Yeah, so one more. You said you gave Dr. Bauer the TTM policy. Are we gonna get can we get a copy in CV just to
No, Dr. Bauer, the CV protocol, the TTM protocol is exactly the same as it's always been. It hasn't changed.
Okay.
But he and I are presenting to the critical care committee on May 4th, May 3rd, right, to talk about that we are going to assure this limitation, that we want everyone who has patients in CVICU to obey the protocol, that everyone needs to look at the 33 versus the 37. And what you will be getting is really a very short thing in the protocol, but you are going to get a user guide to 37 degrees. So right now you have the user guide that I wrote for 33 degrees. What's the difference with 37 degrees is you're going to be all about shivering, but you're not going to be worried about potassium and pain, agitation, sedation, and pharmacodynamics associated with being cold. So like all the glucose, potassium, and all those things, that's going to fall to the background in the 37-degree protocol. So it's the 37-degree protocol is way less intense for the nurse, except for the fact that it has been shown that persons at 37 degrees have a much higher degree of shivering because no one is actually following their water temperature and actually using aggressive sedation. So I love what you've asked. So those adaptations will be shortly after May 3rd, but the protocol that is embedded right now is the protocol you should be following.
Okay.
Okay.
Sounds good.
Yes, I think it is good. I mean, you know, we have to be flexible and change with the times and reevaluate and then say, did it work or did it not work? And I think for us, it isn't working to be gathering all these patients. So,
yeah.
I think, and I always want to separate, although it's very much in my heart, staffing issues, because I want to always do what's right for patients, just like everybody, but I don't think this is right for patients. I think it's a terrible burden on the staff. I think it's been morally and ethically distressing. I can see how much it's wearing on everybody, but in addition to that, it isn't good for the patients. So we feel that it's not yielding any improved outcomes at this point. So we want to go back to what we did before, because what we did before, we did about 45 to 50 patients per year in TTM. And we probably had 2 to 4 patients per year who had some good outcome, which is about what you expect. It's about what you expect. But now we've had almost 60 patients since we made this change, and we really haven't had any good outcomes. So
Not really.
yeah. So that's why. So I want you to know, because I know a lot of people came to me and talked to me about it. I really hear what you're saying. And I really, I myself already had a bias that I didn't think it was the right change to make. And so I was really happy to hear from folks and then to be able to move that forward. So thank you for sharing your concerns with me so that I can help move things forward and have good communications.
Thank you, Ms. Barbara.
You are so welcome. If there are no other questions, I'm going to say bye-bye for now. I'll see you next Tuesday. And thank you again for being generous and understanding yesterday that I had to be in 7K North for about 10 hours last night. So thank you so much for understanding. And I'll see you later. Bye-bye.
See you later, Miss Barbara.
Thank you so much.